and welcome to the Wisconsin Sleep Society Virtual Fall Conference 2021. I am Dr. Alexander Villarreal, Chair of the Department of Sleep Medicine at Gunderson Health System in La Crosse, Wisconsin. Counting my fellowship training, I have 16 years of experience treating people with sleep disorders. I have collaborated closely with dental professionals in the co-management of sleep disorders along my fellowship training and professional career. For those attending the semi-live portion of the conference, there's a chat function where you will be able to type in your questions. Also, I would like to take the opportunity to thank the Wisconsin Sleep Society and the American Academy of Sleep Medicine for making this conference possible. I have no conflicts of interest to disclose. This activity has been planned and implemented in accordance with the accreditation requirements and policies of the Accreditation Council for Continuing Medical Education, ACCME, through the joint providership of the American Academy of Sleep Medicine and the Wisconsin Sleep Society. The American Academy of Sleep Medicine is accredited by the ACCME to provide continuing medical education for physicians. We are also offering PACE credits for this talk. And at the end of this presentation, I would expect you to identify medications that could worsen bruxism, identify complications associated with dopaminergic agents, and being able to name disorders that could affect bruxism. Let's start by defining what sleep movement disorders are. These are simple, usually stereotyped movements that disturb sleep or its onset. Sleep-related movement disorders include restless leg syndrome, periodic limb movement disorder, sleep-related leg cramps, sleep-related bruxism, sleep-related rhythmic movement disorder, benign sleep myoclonus of infancy, sleep-related movement disorder due to medical disorder, and sleep-related movement disorder due to a medication or substance abuse. Let's start by talking about restless leg syndrome, also known as RLS or Willis-Eggbom disease. It's known colloquially by many names, and I invite you to look at the rlshelp.org website to see some of the many names that people call it. RLS affects between 5 to 15% of the population, mainly women, and only a third of people affected seek medical attention. There is a higher incidence in people with Northern European ancestry, and this is why it's so relevant here in Wisconsin. Not a single gene has been identified as a unique cause of restless leg syndrome. Almost 2/3 of people with this condition have a first-degree relative affected, and there have been at least 6 different genes that could play a role. And there's been a linkage reported to chromosomes 12q, 14q, and to 9p24-p22. The pathophysiology, we have a hypoactive endogenous opioid system involved, low brain iron concentrations, abnormal brain dopamine metabolism, a combination of the above factors. CNS and spinal cord could be involved, and there tends to be, as we mentioned, a strong genetic risk. Additionally, low levels of iron, kidney failure, diabetes mellitus, neuropathy, spinal stenosis, Parkinson's disease, and pregnancy increase the risk for restless leg syndrome. To establish a diagnosis, all we need is an adequate history and physical. The diagnosis is always clinical. Sleep studies are not needed. And in 2012, the International Restless Leg Syndrome Study Group revised diagnostic criteria. All criteria must be present. First, there has to be an urge to move the legs. Secondly, this urge or unpleasant sensation begins or worsens during periods of rest. Third, the sensation or urge is improved or relieved partially or completely by movement. And number 4, the symptoms have a circadian pattern, being worse in the evening or at night. Finally, all of these symptoms cannot be accounted for by any other medical or behavioral condition. To remember, there is a mnemonic, which is called urge N. So urge to move, rest-induced, gets better with activity, evening and night accentuation, and not caused by other conditions. Amongst the differential diagnoses, you have several things that you could add and consider. So you have more common and less common ones. Additionally, people with restless leg syndrome can have some supportive clinical features. These include periodic limb movements, either during wakefulness or sleep, response or clinical improvement to dopaminergic therapy, a family history of restless legs syndrome amongst first-degree relatives, and lack of profound sleepiness. So, how do we diagnose restless legs in a person who has a cognitive impairment? First, we look at signs of leg discomfort, such as rubbing or kneading of the legs, groaning while holding the lower extremities. Secondly, we see that these symptoms tend to be worse during periods of rest or inactivity. We can also observe that this discomfort is diminished with activity, and we see that there tends to be excessive motor activity of the lower extremities, such as pacing, fidgeting, repetitive kicking, tossing and turning in bed, slapping the legs, etc. Finally, we see that all of these behaviors are observed only or mainly the evening and or at night. What about the restless leg syndrome in children? It affects close to 2% of children and adolescents. About most of them had symptoms prior to the age of 20, and 10% report symptoms before the age of 10. It happens more commonly in kids with ADHD. To diagnose the problem, we have some modification of the urge criteria. So all of the urge criteria must be present, but the child should be able to describe this leg discomfort in his or her own words. Alternatively, the urge criteria must be present, and there has to be true supportive criteria. So what are the supportive criteria? Periodic limb movements greater than 5 events per hour during a sleep study, family history of restless leg syndrome among first-degree relative, a family history of periodic limb movements greater than 5 events an hour, or family history of PLMD amongst first-degree relatives. In order to quantify how these symptoms affect a person and their overall quality of life and monitor treatment, we tend to use some scales. One of the most popular ones is the one created by the International RLS Study Group. And these questions include 10 items with a 0 to 4 scale, starting with how would they rate the RLS discomfort overall? How would they rate their need to move around because of their restless legs, how much relief do they get while moving around, how severe their sleep disturbance is as a result of RLS symptoms, how severe their tiredness or sleepiness is from their restless legs symptoms, how severe their RLS is as a whole, how often do they get RLS symptoms in days per week, what is the duration of their RLS symptoms in hours, how severe is the impact of restless legs on their ability to carry around their overall daily affairs, and how severe is the mood disturbance caused by restless leg symptoms. As we mentioned, the scale goes from 0 to 40. The higher the score, the more severe the symptoms. The lower the score, the less severe the symptoms. And this can help monitor response to treatment. So if you have someone who came to you with a score of 30, you start them on treatment, and they see you back and they're down to a 15, yet they still complain of problems, you can sort of quantify improvement of symptoms this way. Now, classification of restless leg syndrome. It can be primary or secondary. Primary cases can include iron deficiency in about half of the cases. They might not be related to other disorders. They can be idiopathic or familial, and they tend to occur earlier in life, sometimes adolescence. Whereas secondary cases tend to happen again with iron deficiency, anemia, end-stage renal disease later in life, and symptoms oftentimes tend to be more significant than with primary RLS. History is king, so you can make the diagnosis clinically. Sleep studies, again, polysomnography, is not needed or indicated unless you're suspecting something else that can be diagnosed with a sleep study. An electromyogram would be performed only if there is suspicion for coexisting neuropathy, radiculopathy, or myelopathy. Imaging studies of the central nervous system are typically not needed unless you're suspecting myelopathy or strokes. There are several laboratory tests, but you don't order them routinely, with the exception of iron studies or serum ferritin. So how do we treat restless leg syndrome? First, we have non-pharmacological therapies. Non-pharmacological therapies should be implemented first. And there are several interventions which include mild to moderate physical activity, adequate sleep hygiene, hot baths, massages, engrossing mental activity such as meditation, acupuncture, scheduling sedentary activities earlier in the day and more active exercises or activities later in the evening, avoiding triggers such as caffeine, nicotine, we'll discuss that later on, and compression devices. The American Academy of Neurology came with some guidelines in 2016 and various therapies, and these are the summary of the non-pharmacological therapies. They include pneumatic compression, which tends to be effective, but it is difficult to implement when the patient is ambulatory. They have to be laying down in bed typically when this is occurring. It can also include near-infrared spectroscopy, repetitive transcranial magnetic stimulation, vibrating pads, transcranial direct current stimulation, a foot wrap with targeted pressure, and of course, exercise. Exercise tends to improve restless leg symptoms quite well when there is aerobic and resistance exercise. Pneumatic compressions and yoga also tend to help with restless leg syndrome. And Something that's very important before you start any medications, see if you could discontinue medications that worsen restless legs, if at all possible. These include antihistaminic agents, antidepressants such as SSRIs, SNRIs, tricyclic antidepressants, mirtazapine, atypical antipsychotics, antiemetic agents, stimulants such as amphetamines and methylphenidate, alcohol, caffeine, nicotine, and proton pump inhibitors as they interfere with iron absorption. Pharmacological therapy. We'll talk about agents that are FDA approved. So we have two groups. The first are the calcium channel alpha 2 delta ligands, which include gabapentin encabril, and we have non-ergot derived dopaminergic agents, which include ropinirole, pramipexole, and the rotigotine transdermal patch. So let's start with the calcium channel alpha 2 delta ligands. As we mentioned, out of this group, only gabapentin encabril is FDA approved. The other two are not, but there is plenty of evidence showing that they can be helpful in treating restless leg symptoms. This group is now favored as a first-line agent to treat restless leg symptoms. Gabapentin tends to be the drug of choice. There tends to be no augmentation or impulse control disorders. They can be quite beneficial if there are symptoms of insomnia with restless leg symptoms because they provoke some sedation. And they can also be considered in people with anxiety or impulse control disorders. You have to be aware that they can cause weight gain and that they have a small risk for addictivity, so they tend to be a Schedule 4 drug. Gabapentin tends to be the least costly of this group. Pregabalin can also be used. The main difference between gabapentin and gabapentin encabril, which is a prodrug, is that gabapentin is not absorbed in the gut as reliably as gabapentin encabril, and therefore a gabapentin failure does not reflect into gabapentin encabril not working for that person. We also have dopaminergic agents. Dopaminergic agents can be classified in non-ergot derivatives and ergot derivatives. The one thing you have to know about the ergot derivatives is that you should not use them. Why? Because they can cause cardiac valvular fibrosis and pulmonary fibrosis. So just don't use them. About the non-ergot derivatives, they've been shown to be quite effective in treating restless legs and periodical limb movements. There's a risk for augmentation. This means that over time the symptoms can get worse. We'll explain that in a future slide. They include ropinirole, pramipexole, and the rotigotine transdermal patch. Be aware that we can utilize opioids for refractory cases of restless leg syndrome. This was well studied by the group in the Mayo Clinic in Rochester, Minnesota, and they've been shown to be quite effective when treating people who have not responded to dopaminergic agents or alpha-delta ligands. That causes significant impairment of quality of life. It's also very important that before we start someone on an opioid, that their iron stores are well maintained. And the two drugs that are most commonly recommended are oxycodone at a dose of 10 to 30 milligrams daily, or methadone, 5 to 20 milligrams daily. Other opioids that have been used are tramadol, codeine, morphine, hydrocodone. If these medications were to be prescribed, it's very important to have a medication user agreement in place because of the addictivity potential, making sure that you have routine drug screens in place, and that you carefully screen for possible sleep disordered breathing before starting these medications because of the adverse effect that would occur in a person who had untreated sleep disordered breathing. It's very important to reevaluate this patients uh, frequently to monitor for effectiveness of treatment and side effects. Be aware that dopaminergic agents can cause several adverse effects, including nausea, which is the most common one, fatigues, dizziness, vomiting, sleep attacks, especially at higher doses. But one of the more troublesome are the impulse control disorders. So what are these impulse control disorders? The prevalence tends to vary. Usually it is more significant at higher doses. It also happens with those dopaminergic agents that have a higher D3 affinity, such as pramipexole. Younger males with a history of psychiatric symptoms tend to be most affected. And the longer they stay on this, the higher the risk of this occurring. It can also affect motor complications in people with Parkinsonian disease. And I've witnessed some sad cases, including a person who's lost their marriage, their job, and everything after being successful for many, many years due to gambling. So all this is unfortunately very real. So you have to monitor them very, very closely and carefully. So moving back to the RLS guidelines published by the American Academy of Neurology, we have that pharmacological agents shown to be helpful in the treatment of restless legs include pramipexole, the rotigotine patch, gabapentin, ropinirole, pregabalin, IV iron, oral iron, levodopa, carbidopa, and these are the doses and the ranges that you can utilize, including their FDA approval. These are again more like a dosing of medications you can use, including opioids. And be aware that there is insufficient evidence to recommend the following medications for the treatment of restless legs, including common ones such as clonazepam and clonidine in adults. What about children with restless legs? What are the medications that we recommend the most? And mainly iron. You want to use that. I would be extremely careful prescribing dopaminergic agents, maybe even refrain from doing that. Gabapentin, maybe in the most extreme cases, clonidine can be trialed. And during pregnancy, the main thing is to monitor for iron deficiency, replace iron if ferritin levels are below 75 nanograms per milliliter. And in the most rebellious cases, long-acting levodopa carbidopa can be helpful. So now let's talk a little bit about augmentation. This was first described by Allen and Early in 1996. And it is described as being a severe and disabling exacerbation of restless-leg symptoms that can increase the severity and the duration of these symptoms, sometimes lasting as long as 24 hours. And that these worsening starts after starting the medication used to treat restless legs. There's a medication effect that's dose-dependent, and symptoms, as we mentioned, become progressive. The Max Planck Institute in Germany devised the following diagnostic criteria for the detection of augmentation, and it is after initial response to a therapeutic agent, there is worsening of symptom severity, not accounted by other factors that occurs most days. Additionally, symptoms have a longer duration and appear at an earlier schedule. Augmentation occurs mainly with dopaminergic drugs. All of them are involved, much more with levodopa carbidopa. And it can be quite tricky to manage. Sometimes trying to split the total dose or extending the release form, but oftentimes what it takes is to discontinue gradually and switch to an alternative non-dopaminergic agent, such as a calcium channel alpha 2 delta ligand. There's also rebound and tolerance. Rebound is an increase of symptoms that occurs after initial decrease of the pharmacokinetic effect in the person's system. And this would be worsening of symptoms that occur in the morning after the medication is no longer present in their system. Tolerance is when the medication gradually loses its effectiveness. Then you need a higher dose to achieve the same symptom relief. I would also like to mention this study, which was very interesting and tells you about how challenging some of these restless-leg syndrome patients can be. But this was pulled from 85 randomized controlled trials studying the response to pharmacological agents versus placebo. And they aggregated all of these and searched for the response to placebo and also the report of adverse effects with placebo. And you can see that about 40% of patients responded to placebo and 45% reported adverse effects with placebo. To this effect we call nocebo. So again, RLS can be quite challenging to treat. With several patient resources, the Restless Legs Syndrome Foundation, National Sleep Foundation, and Sleep Education, please direct your patients there. Now, let's talk about periodic limb movement disorder. The International Classification of Sleep Disorders, 3rd edition, defines it as periodic limb movements of sleep during a sleep study, frequency that occurs more than 5 times an hour in children or more than 15 events an hour in adults. Also, these periodic limb movements cause a sleep disturbance or daytime impairment and are not better explained by another disorder. Sleep-related cramps are defined as leg or foot pain associated with a strong muscle contraction. This occurs during time in bed or sleep. The pain is relieved by forceful stretching of the affected muscles. Cramps tend to affect children and adolescents, about just 7%, pregnant women, 40%, adults older than 60, 33% report at least once a month, and 6% every night. And adults older than 80 tend to be more affected. About half of them report at least one episode every other month. There are several factors that can predispose to having leg cramps, including diabetes, ALS, vascular disease, electrolyte abnormalities, metabolic disorders, vigorous exercise, dehydration, cirrhosis, hemodialysis. And there's also several medications that could add to this problem, including oral contraceptives, intravenous iron, medications that help treat osteoporosis, diuretics, long-acting beta agonists, use inhalers, and statin agents. Sleep-related bruxism. All criteria must be present. First, there should be a regular or frequent tooth grinding that occurs during sleep. Additionally, there should be abnormal tooth wear, transient morning jaw pain, temporal headaches, and jaw locking. A sleep study is not needed to make the diagnosis, but increases the reliability of the diagnostic. Sleep-related bruxism is different from awake bruxism. Sleep-related bruxism can be either primary or secondary. Primary bruxism occurs more often in healthy children and adults. As you can see, the prevalence tends to decrease with age, occurring more frequently in younger children and most rarely in elderly, pretty much the opposite of leg cramps. Whereas secondary bruxism occurs due to other things such as psychoactive medications, recreational drugs, cerebral palsy, neurodevelopmental disorders, movement disorders, or obstructive sleep apnea, which is a pretty big one. If we do a sleep study, what are the things we find there? We find something called rhythmic masticatory muscle activity, or RMMA, which are jaw muscle contractions that are repeated over time. These contractions can be of two types. They can be phasic, if they're repetitive, or tonic, if they're isolated and sustained. So what are the scoring rules for bruxism during a sleep study? First, we can find phasic or tonic elevations of the chin EMG that's at least twice the amplitude of the background EMG. Two, there has to be increased chin or masseter EMG of 0.25 to 2 seconds in duration that occur in 3 regular sequences. The sustained chin or masseter EMG has to last more than 2 seconds, and there has to be 3 seconds of stable background EMG in between episodes. If you find 2 audible tooth grinding per night without epilepsy, can also be supportive. What about medications that could induce bruxism? So we have medication classes and some individual medications. Amongst classes, we have anticonvulsants that can actually increase and cause bruxism. There's also the phenethylamines, or stimulants such as amphetamines, methamphetamine, methylphenidate can cause it, SSRIs, SNRIs. Individual medications, you have aripiprazole, which is an atypical antipsychotic, which is a partial dopamine agonist. Atomoxetine, used to treat ADHD. Flecainide, used to treat some issues with atrial fibrillation and antiarrhythmic. Ketotifen, and methadone. There's also several addictive drugs that can potentially induce bruxism, and these include alcohol, heroin, methamphetamines, MDMA, nicotine, and piperazines. What about medications that can actually help bruxism? These include amitriptyline, botulinum toxin, buspirone, clonazepam, clonidine, clozapine, gabapentin, hydroxyzine, levodopa, carbidopa, propranolol, quetiapine, and trazodone. I would be careful about prescribing medications unless everything else had failed. Once again, be very careful with medications that are potentially addictive or habit forming, such as the clonazepam and gabapentin. Careful with the dopaminergic agents, as they can cause troubles, and also careful with the atypical antipsychotic quetiapine, as they can have many other side effects, as increased weight gain and involuntary movements. Now, regarding the treatment for sleep-related bruxism, there's really no single current medication or treatment proven to be effective under like randomized controlled trials. However, recommendations include avoiding triggers such as alcohol, nicotine, drugs, if at all possible, neurofeedback, CBT, occlusal appliances, which becomes very important to protect their teeth, and this is where dentists come pretty handy. Medications. Again, in the sleep clinic, we see a lot of people who have issues with bruxism who could benefit from treatment and protection of their teeth. What about sleep-related rhythmic movement disorders? These are repetitive, stereotyped rhythmic motor behaviors. These movements are predominantly sleep-related, or when drowsy behaviors result or interfere with sleep or impairment. And there could be some self-inflicted body injury, although that's pretty rare, and movements are not better explained by other disorders. These could include body rocking, head banging, head rolling, rolling of legs, body, or a combination of these things. These occur a lot more in younger children, and as they grow, these movements tend to subside. Oftentimes, It is parents who are concerned about their children moving around or banging their heads that come talking about this. They're pretty rare in adolescence and adulthood, and most children are developmentally normal. If these behaviors are also occurring while the child is awake or the person's awake, then there should be a concern for autistic spectrum disorder, as in its purest form, it only happens in that transition time from sleep to awake. But if it also happens when awake, then you have to look into those stereotypical movements that can occur in autistic spectrum disorder. Once again, injuries are rare. What about the benign sleep myoclonus of infancy? These are repetitive myoclonic jerks involving limbs, germs, or the whole body. It occurs again in early childhood, up to the first to 6 months of age. It only occurs during sleep, and it stops if the child is awakened. It's also not better explained by other conditions. This is usually very benign, and there's nothing to be too concerned about. Then we have the propriospinal myoclonus at sleep onset. This is pretty much mentioned as sudden jerks of the abdomen, trunk, or neck. They appear during relaxed wakefulness and drowsiness as the person is attempting to sleep. And they disappear when the person is fully awake or once they're fully asleep. These jerks cause difficulty sleeping, and they're not better explained by another sleep disorder. And they can be quite bothersome to that person who's trying to sleep, and as soon as they're trying to sleep and their body's relaxing, they find themselves like jerking. Then we have sleep-related movement disorders due to medical conditions. And again, there is a clear medical condition that can cause these movements. Example, say Parkinson's or someone who had a stroke. And then we have sleep-related movement disorders due to a medication or substance. And again, this could happen with people who are either in withdrawal or due to medications. So again, that tends to appear with the history. So to summarize, sleep-related movement disorders are prevalent. Please review their health problems and their medication list. Remove any offending agents if you can. Start with non-pharmacological treatments first. If they have restless legs, check ferret and iron levels and replace iron if levels are below 75 nanograms per milliliter. Dopaminergic agonists have several adverse effects, so please monitor cautiously if you prescribe. So with that, I want to thank you and leave this open to questions.